think about the incredible force of pressure, the kind deep in the ocean, and then think about oxygen, the very essence of life.
Right.
Now, what if we could actually harness that pressure and that oxygen in a controlled way to speed up healing, maybe even fight serious diseases?
That's a fascinating idea, really.
That's the world of hyperbaric chambers we're diving into today.
It really is remarkable when you stop and think about it. We just live our lives at, normal atmospheric pressure, breathing air, don't give it a second thought.
Exactly.
But when you start intentionally changing those conditions, medically, the possibilities get pretty profound.
And that's precisely what we want to explore. For this deep dive, we've got a fantastic resource, a really detailed chapter. It covers, well, everything. Different types of chambers, the science behind how they work.
They're pressurized magic, you could say.
Yeah. And crucially, all the safety stuff.
Yeah.
It's key.
Absolutely. So our goal today is kind of to navigate through some of the technical jargon, and really pull out the key insights for you, the listener.
We want everyone to get a clear picture what these chambers are, how they're used in medicine, and why safety is just non-negotiable.
Couldn't have said it better. Let's get started.
All right, let's kick off with the most common type you tend to see. Monoplace chambers.
Right, the single-person ones.
These are typically pressurized up to about 3 ATA. Now, ATA, that's atmosphere's absolute.
Correct. So 3 ATA is roughly 3 times the normal air pressure we feel right now at sea level.
Okay. And importantly, these use 100% pure oxygen.
They do. And what's interesting is how that oxygen gets in there. There are basically 2 main ways. Some use what's called constant purging. So fresh oxygen just flows in continuously, pushing out the old gas. Think of it like always having a window open, but with pure O2.
Okay, constantly refreshing.
Exactly. Others use a recycling system. They basically clean the air inside the chamber, pull out the CO2 and water vapor the patient breathes out, and reuse the oxygen.
Got it. 2 different strategies for the same goal. Pure oxygen. So why are these monoplace chambers the go-to options so often? What are the advantages?
Well, there are quite a few, actually. A big one is individual patient treatment. You get privacy, which matters, and crucial isolation. If a patient has an infection, you definitely want them isolated. 1 patient, 1 chamber. Simple as that.
Yeah, that isolation piece sounds huge in a hospital, preventing spread. What else?
They're also really convenient for moving patients around. Some models, like the OxyHeal 1000 series, actually have a built-in stretcher.
Oh, neat.
Yeah. So you can take a patient from, say, the recovery room to another area without interrupting the hyperbaric treatment. That continuity is a real plus.
Okay. And what about comfort? I mean, being sealed in a tube with pressurized oxygen, does it feel weird?
Patients often find it surprisingly okay. Because it's all pure oxygen inside, they don't need to wear a mask.
Right. No mask hassle.
Exactly. No leaks around the face, none of that irritation. And that also makes them really good for patients who are bedridden, like maybe someone with paraplegia.
Makes sense.
Plus, staff can easily see the patient through the clear walls. And usually there's no need for complex or long decompression after the session.
So good for the patient and also relatively easy for the staff to manage.
That's a good way to put it. They also tend to need less space, can be more cost-effective than bigger systems, and typically require fewer operators.
Okay, those are definitely strong points for monoplace chambers. But, there's always a flip side. What are the downsides or limitations?
Well, the big one, given that it's 100% oxygen, is the fire hazard. It's an oxygen-rich environment, so fire risk is significantly higher.
Right. That's a major safety concern. We'll definitely need to circle back to that.
Absolutely. Another thing is direct access. In most standard designs, it's hard for medical staff to physically reach the patient during the treatment. There are some modified designs, like the Renault dual compartment chamber, that improve access, but it's a general limitation, so it's kind of a trade-off, you see.
Simplicity and individual focus versus needing complex hands-on care inside.
Exactly. The pure oxygen environment limits what you can easily do medically inside.
What about things like ventilators or IV meds?
That's another limitation. The ventilators used in monoplace chambers are often, less advanced. This might mean the patient needs more sedation, maybe even muscle relaxants, and IV medications. You need special pumps located outside the chamber, running long lines in. This setup, there's a potential for inaccuracies in drug delivery. One study, Lind 2015, pointed this out.
So getting precise drug doses could be tricky.
It can be more challenging, yes. Also, physical therapy inside. Pretty much impossible in that confined space.
Right.
And think about decompression sickness. If a patient gets agitated, giving them an air break, switching them to breathing normal air is tough because they can't easily put on a mask themselves if they're not cooperating.
So it sounds like monoplace chambers are really best for patients who are fairly stable, don't need constant hands-on intervention inside the chamber itself.
That's generally true. Monitoring vitals, even controlling the respirator, can often be managed effectively from the outside.
You mentioned some examples earlier. Could you expand on those, the different types?
Sure. The C-crace chamber is one you see a lot in the U.S. Very common. Then you have designed specifically for acute care or ICUs.
Okay.
And then there are portable options, like the Hyperlight folding chamber from SOS Ltd in London.
A folding chamber.
Yeah. Lightweight, rapidly pressurized on site, really useful for emergencies, diving accidents, trauma, maybe even early stroke treatment.
Wow, a portable hyperbaric chamber for stroke during transport. That could be revolutionary.
It really could. And speaking of portability for emergencies, there's the Gammo bag.
Right, for altitude sickness.
Originally, yes. But it's evolved into things like the Chamberlight 15. These are transportable, handle higher pressures, and can deliver standard HBO therapy for things like CO poisoning or decompression sickness. A study by Shimada back in '96 highlighted this.
So portable options are becoming more sophisticated.
Definitely. And there's real interest in using them for acute stroke treatment during transport. Getting that oxygen in early could make a huge difference.
From backpack-sized bags to integrated hospital units.
Yeah.
The range is pretty amazing. Okay, let's switch gears now. Multiplace chambers. These sound bigger.
Much bigger, usually. Designed to treat multiple patients at once, maybe just a few. Or up to 20 in the really large ones.
20 patients.
Yeah. And here's a key difference. The chamber itself is filled with regular compressed air, not pure oxygen.
Ah, okay. So patients breathe the oxygen differently.
Exactly. They wear masks or hoods inside to breathe the 100% oxygen.
So the air inside the chamber isn't pure oxygen? That seems like a big safety difference.
It is. It dramatically reduces that fire hazard we talked about with Monoplace.
Right.
These multi-place systems also have pretty complex gas supply and monitoring setups. Air conditioning, too, to control humidity and temperature precisely. Makes it comfortable and safe for patients and any medical staff inside.
Staff can go inside, too.
Absolutely. That's another major advantage.
What are some examples of these multi-place chambers?
In the U.S., you might see the dual OxyHeal 2000, that's like 2 linked chambers, holds up to 4 people. Then the OxyHeal 4000 is bigger, 3 compartments, up to 18 patients, often set up for critical care.
18.
And the OxyHeal 5000 is a rectangular one, holds 12, also typically for critical care. And these often go to higher pressures, too. The 4000 can reach 6 ATA, for instance.
6 times atmospheric pressure. So what are the main reasons to use these big chambers?
Well, treating many patients simultaneously is obviously huge, especially for things like disaster response. But maybe even more importantly, they're essential when you need doctors or special equipment inside with the patient.
Like a pressurized operating room.
In some cases, yes, or for intensive care. And, as we said, the fire risk is much lower because it's pressurized with air.
That lower fire risk must open up other possibilities, too.
It does. You can actually do physical therapy inside. Some facilities have treadmills in there.
Really? Treadmills under pressure.
Yep. Great for research and rehab for stroke patients, peripheral vascular disease, heart issues. They exercise under pressure while staff monitors them right there.
That's incredible. Rehab and research combined.
It is. And there's even this concept of brain jogging, using computer exercises for patients with cognitive issues, all while they get their HBO treatment.
Fascinating.
Plus, because they can reach higher pressures, like 6 ATA, they're crucial for treating severe conditions, serious air embolism, or decompression sickness cases.
So for complex cases, critical patients, or when you need staff inside, multiplace is the way to go.
Generally, yes. They really function as an extension of the ICU. You can do standard critical care, mechanical ventilation, suctioning, hemodynamic monitoring, blood gas tests, even CPR, all safely inside. That Lind 2015 comparison highlights this.
A pressurized ICU,
Yeah.
essentially. But I imagine running that kind of setup, multiple patients, staff, equipment, all under pressure, must be way more complex operationally.
Oh, absolutely. It's a significant undertaking. Coordinating everything, managing the technology. It's complex. And while you can do some minor procedures, major surgery requires specially designed hyperbaric operating rooms.
Which aren't common.
Not really. Some exist or existed in places like Japan, the former USSR, a few spots in Europe. But hyperbaric surgery has its own unique technical hurdles, especially with things like electric cautery tools.
Right, electricity and pressure. Tricky combo. Okay, we also mentioned mobile chambers earlier, bringing the treatment to the patient.
Exactly. The very first one was actually built onto a bus in Japan, though it's not running anymore.
A hyperbaric bus.
Yeah. Today, there are more modern mobile units, like the OxyHeal 4000 mobile chambers. There's one in Houston that's been running continuously since 1990. Another in Park Ridge has roots going back to the 60s when they actually did surgeries in it.
So mobile hyperbaric care isn't brand new. What's the big advantage?
Mobility, obviously. You can drive it right to a hospital, park it outside, provide immediate HBO access.
Wow.
They usually have the same comfort and safety as fixed multiplace units. Good for clinical use, research. Huge potential in military medicine, too closer to the front than transferred to base hospitals.
And for emergencies.
That's key. The potential to start HBO treatment during long-distance transport for things like stroke, heart attack, CNS injuries. That early intervention could dramatically improve outcomes.
Taking a pressurized ICU on the road.
Huh.
Powerful stuff. Okay, we've covered monoplace and multiplace pretty well, but you said there are other, more specialized types too.
Yes, indeed. There are chambers built specifically for testing and training divers. You often find these at facilities that also treat diving accidents, like at the University Hospital in Zurich. They can simulate really deep dives.
Makes sense for diving medicine. What else?
Well, there are chambers designed just for animal research. They range from small, portable ones for, say, newborn animals up to quite complex setups.
Okay.
And then it gets even more specialized. Things like the OxyCure 3000 Hyperbaric Cellular Incubator.
An incubator.
Yeah, for research at the cellular level, studying stem cells, for example. It gives researchers precise control over pressure, gases, temperature, humidity, all in that pressurized environment.
So hyperbaric tech goes right down to the cellular level. Amazing.
It does. And speaking of research, there's a really neat rodent-sized chamber system that's compatible with imaging like CT, PET, and MRI.
So you can image during hyperbaric exposure.
Exactly. Continuously, non-invasively in animal models. Hansen and colleagues described this in 2015. It opens up huge possibilities for understanding what's happening physiologically in real time under pressure.
Being able to see inside during treatment, that's a big leap for research. Now, with all these different chambers, different sizes, pressures, uses, how do doctors decide which one is right?
It usually comes down to classifying them by pressure capability, size, and intended use. Interestingly, most common medical reasons for HBO, maybe 90% or so, can be handled by type I and II chambers. These go up to 2.5 ATA.
Okay.
It's also worth noting that regulations can play a role. In Germany, for example, anything over 2.5 ATA needs inspection by their technical agency, the TÜV. They're very strict.
Higher pressure means tighter oversight. Makes sense.
Exactly. And actually, there's some rethinking happening about needing those super high pressures, like 6 ATA, for decompression sickness or air embolism. Some evidence suggests 3 ATA might be enough for most cases.
Oh, interesting. So the thinking evolves.
It does. Also, these chambers are built to last. Many older ones, if well maintained, are still perfectly functional. And those mobile multiplace units we talked about. They're opening new doors for research and rehab, sports medicine, plus potential cost advantages.
So the tech isn't standing still. Now let's talk about the actual treatment session. What's it like for a patient?
Typically, sessions run at pressures between 1.5 and 2.5 ATA. The whole thing might last around 45 minutes, but that includes time for compression, maybe 10 minutes, to get up to pressure and decompression, maybe 5 minutes at the end for these lower pressures.
And that varies.
Oh, yeah. For serious infections, treatment times might be much longer, even doubled. Chronic conditions often mean daily sessions for a period. And in multiplace chambers, they often group patients with similar conditions. You might even have a physiotherapist working with stroke patients right there in the chamber.
Ah, combining therapies.
Yeah.
What about the feeling of pressure changing? The compression and decompression?
It's usually pretty smooth, well tolerated. If someone feels ear pressure or pain during compression, they can just pause the process, let the person equalize, like on a plane.
Yeah.
And multiplace chambers often have a small separate section, an anteroom. If one patient has an issue, they can be moved there for individual decompression without stopping the main treatment.
Smart design. And remind us how the oxygen gets delivered again in the different types.
Sure, Monoplace. The whole chamber fills with 100% oxygen from the start. You just breathe the air inside.
Right.
Multiplace. The chamber pressurizes with regular compressed air. Once at pressure, patients put on tight-fitting masks or hoods to breathe the 100% oxygen.
Got it. And do they measure the oxygen levels in the patient's blood constantly?
Not usually for routine treatment, more for research or special cases, but we know the levels get much higher. At 1.5 ATA, your arterial oxygen partial pressure might be around 1,000 millioGSU, way above normal sea level values.
So you're flooding the tissues with oxygen. Okay. Now, besides the chamber itself, there must be a ton of other specialized gear involved.
Oh, absolutely. Ancillary equipment is critical for treatment and safety. Think about oxygen masks and hoods for multiplace chambers. They need a really tight seal, don't want oxygen leaking into the chamber air, need to ensure the patient gets that high concentration.
Like pilot masks?
Some are similar, yeah, capable of delivering very high O2 levels, usually made of rubber or silicone, easy to clean. Hoods or tents covering the head and neck can be good for treating lesions there.
What if a patient needs a ventilator?
Then you need specialized ventilators certified for hyperbaric use. Critical piece of equipment. Several models work reliably up to 6 ATA.
Like which ones?
The Seachrist 500A is common in their monoplace chambers. For multiplace, you might see the Penlon Oxford, Siemens Servo, or the air-driven Monaghan 225.
What makes a ventilator good for hyperbaric use?
Key things are no electrical parts inside the chamber itself, that fire risk again, stable volume and rate despite pressure changes, low oxygen leak into the chamber, and continuous flow options to make breathing easier for the patient.
Safety and reliable breathing support under pressure. Got it. What about basic diagnostic tools?
Simple things like reflex hammers, stethoscopes, ophthalmoscopes, non-electric ones should always be on hand.
And more complex monitoring. ECG, EE.
Yep. ECG and EEG are used routinely. High pressure can sometimes affect signal quality a bit, but studies show things like EEG power spectrum and evoked potentials work okay.
What about measuring oxygen in the tissue directly?
That's transcutaneous oxygen measurement, TCPO2. It's non-invasive, useful. But you can't use it in a monoplace chamber.
Why not?
Fire risk again. The electrode it uses gets heated. But it's fine in multiplace chambers, correlates well with arterial O2, often used for vascular disease assessment.
And blood gas tests.
Ideally, you do them right inside the chamber. Taking a sample out to sea level pressure can mess up the results because gases come out of solution. So there's modified equipment for in-chamber analysis. Interestingly, the ratio of arterial to alveolar O2 stays pretty constant under pressure.
Even glucose monitoring needs care.
It does. Some methods are inaccurate under pressure, and higher or low oxygen can interfere with others. Needs careful checking.
Wow, so many details. What about other miscellaneous stuff? CPR, suction.
Yep. CPR gear is essential, but endotracheal and Foley cuffs need to be inflated with water or saline, not air, because air volume changes with pressure.
Ah, right.
Suction can use compressed air or an external source. Special IV kits are needed, especially for monoplace. Treadmills, as we said, need the motors outside.
Defibrillators, that sounds risky.
Hugely risky, big fire hazard. But there are newer models designed specifically for hyperbaric use. Still requires extreme caution and strict protocols.
Okay. What about chest tubes? Pleural drainage.
Needs very careful management during pressure changes. No suction during pressurization, slow pressurization, maybe suction during depressurization if there's an air leak. And equipment needs hyperbaric compatibility testing.
Endotracheal tubes. Tracheostomies.
Humidification is key for ET tubes. Use the largest possible tube because gas density increases resistance. Tracheostomy care can be trickier in multiplace due to gas density. Monoplace might be better sometimes, might need ear tubes for pressure equalization. Use water-filled trach cuffs.
Okay, what about bladder irrigation? Patches, implants.
Continuous bladder irrigation for certain conditions can be done even in monoplace with special setups. Transdermal patches. Generally remove them before going in, though maybe some exceptions like fentanyl patches with specific protocols. Implanted devices. Big concern. Risk of malfunction deep brain stimulators, for example. No universal guidelines yet. Have to contact the manufacturer, do a risk-benefit analysis case by case.
That's a huge range of considerations for seemingly routine medical stuff.
Yeah.
So how are patients actually monitored during the treatment?
It's a mix. Direct visual observation through the walls or via CCTV. Auditory two-way intercoms for constant communication. And then all the diagnostic and monitoring equipment inside or connected from outside.
And the level of monitoring depends on the patient.
Absolutely. Tailored to how sick they are. For critically ill patients in a multi-place chamber, it's basically full ICU-level monitoring, just under pressure.
What about specific challenges, like monitoring a head-injured patient in a monoplace chamber?
That takes some specific techniques. Arterial blood pressure usually needs an indwelling catheter and a pressure infuser bag to keep the line open against the chamber pressure. Central venous pressure, even Swan-Ganz monitoring can be done.
E.g.
Electrodes need careful prep with dry collodion to minimize fire risk. ET tube cuffs filled with saline, not air. Blood gases from the arterial line are fine, but no transcutaneous O2 monitoring because of the fire risk.
Intracranial pressure, brain blood flow.
ICP monitoring is possible with systems like the Richmond bolt. Measuring cerebral blood flow continuously inside a clinical chamber, that's still a really tough technical challenge.
So, keeping close tabs on a head injury patient requires specific adaptations in that environment.
Okay, let's shift to maybe the most critical topic. Safety.
Yeah.
Paramount, absolutely paramount. The biggest physical risk is structural failure leading to rapid decompression. Catastrophic.
How is that prevented?
Strict design and construction codes. In the U.S., it's mostly the ASME boiler and pressure vessels code. Very high standards. The acrylic viewports are designed to show stress signs before failing, and never clean them with alcohol, it damages them. They're also sensitive to heat and radiation.
What about power failures?
Emergency backup power is essential. Must keep critical controls and monitors running.
And the air inside?
Rigorous atmospheric control. Gas supply needs careful management, whether from compressors, accumulators, or liquid sources. And regular checks on air composition and purity are crucial. There are specific safety standards for that.
Okay, what about the breathing systems in multi-place chambers? BBs, you called it.
Yeah. Right. Built-in breathing system. Delivers the oxygen, usually 100% via those tight masks. Crucially, they have an overboard dumping system. It vents the exhaled breath directly outside the chamber, prevents CO2 buildup, keeps the chamber air normal. If using hoods, you need good CO2 removal and humidity control inside the hood, and always humidified oxygen to prevent drying out airways.
Right. Now, fire safety. We know it's a risk, especially in monoplace. What's the real story there?
Okay, historically, the overall safety record is actually pretty good, considering the potential. But you have to understand the risks and follow protocols religiously.
When did the first fires happen?
First documented one was way back in 1923. An analysis from 1923 to 1996 found fatalities were almost always in oxygen-enriched atmospheres. Ignition sources were initially electrical, later often prohibited items brought inside.
So pure oxygen is the common factor in fatal fire.
Yes. Survivors were typically in air-pressurized chambers. The first monoplace fire was in Japan, 1967, linked to things like hand warmers, static electricity, igniting stuff in fiberglass trays.
Human error seems like a factor, too.
Sadly, yes. A fatal monoplace fire in Naples in '87 involved a toy pistol brought inside. Lacks supervision.
What about multi-place fires?
First reported, one involved an externally heated microwave blanket brought in. A fatal explosion in Milan in '97 was likely due to a gas hand warmer used in an oxygen-pressurized chamber, which shouldn't happen.
But things are better now.
Thankfully, yes. No reported fires in the last 5 years reported in our source. That suggests current protocols are effective when followed.
So it's that deadly mix. Combustibles, high oxygen, ignition source, maybe inadequate extinguishers, banned items.
Exactly. And the risk is undeniably higher in 100% oxygen monoplace chambers.
So prevention in monoplace is about
eliminating ignition sources, absolutely NO electrical gear inside, no static-prone clothing like nylon, no oil-based cosmetics, and clear, fast procedures for emergency decompression if there's any hint of fire.
And for multiplace, there are specific guidelines.
Yes. The U.S. National Fire Protection Association, NFPA, has detailed standards. Things like intrinsically safe equipment, explosion-proof wiring, waterproof circuits, limits on volatile liquids, specific lubricants, using air or hydraulic motors instead of electric where possible.
Keeping oxygen levels down.
Keeping the chamber atmosphere below 23% oxygen. Having fire detection manual and automatic. And fire extinguishing systems, usually pressurized water deluge systems, handheld hoses, plus regular drills. NFPA 99, Chapter 19 covers this.
But NFPA doesn't have guidelines for surviving a fire in a pure oxygen monoplace chamber.
No, because the risk is considered so high, the focus is entirely on prevention. Even using portable chambers in regular rooms needs precautions, clearing combustibles, keeping distance from electrics, removing static-prone items.
It's incredibly clear how vital strict protocols and training are. Okay, briefly, what about the regulations governing all this?
It's a bit patchy globally, no single authority everywhere. In the U.S., the FDA has become more involved. They classify oxygen as a drug and hyperbaric chambers as Class 2 medical devices.
Since when?
Since 1976, pre-76 chambers are mostly grandfathered in. Class 2 devices need general controls, meeting standards like NFPA 99 and ASME PVH01, and getting FDA clearance via a 510(k) submission before marketing.
And manufacturing standards.
Yeah. Yes, FDA's Good Manufacturing Practice, GMP, regulations apply. Similar to ISO standards. Covers design, production, testing, controls, documentation, registration. It's feasible for manufacturers, but needs commitment to procedures.
What about advertising?
FDA has rules about labeling and prohibits manufacturers from saying FDA endorses their product just because it has 510(k) clearance. And they forbid selling adulterated devices unregistered factory, no clearance, not built to spec.
And elsewhere.
Varies. Europe has a code of good practice. Germany is very strict, requires 2 certification, follows GTUM quality guidelines, excellent safety record there, but partly because they currently only allow multi-place chambers due to fire concerns.
So a mix of national and international standards to follow.
Yep.
Lastly, who runs these places? Staffing.
You absolutely need properly trained people. Hyperbaric technicians handle the chamber operation. Safety, no basic hyperbaric medicine. Hyperbaric nurses provide patient care before, during, after need to know the chamber operation and the medical conditions being treated.
What about round-the-clock services?
Nurses and critical care specialists involved need deep knowledge of hyperbaric physics, physiology, compression, decompression management.
Is it safe for the staff working inside?
Occupational health is important. There's a small risk of decompression sickness for attendants, but minimized with oxygen breathing and staff rotation. Ear trauma is possible, but overall the safety record for staff is very good. Only 1 reported death found in the literature for attendants.
So it takes a dedicated, specialized, well-trained team. Okay, as we wrap up this deep dive, what are the main takeaways?
Well, we've seen there's a real variety of chambers, monoplace, multiplace, mobile. Choosing the right one, plus the right ancillary gear, depends on needs and resources. That's the physician's call.
And safety.
Generally very safe if precautions are rigorously followed, but there's always room for improvement, especially in patient monitoring technology inside the chamber.
The basic tech is solid, but still evolving.
Exactly. Gas supplies, chamber materials, controls, monitoring, safety devices all continue to improve, often tailored to specific chamber types, whether for treatment, training, or research. But the non-negotiables: alarms, technical monitoring, firefighting gear, pressure locks, and good patient monitoring in therapeutic chambers.
A really complex blend of medicine, engineering, and safety. Thanks so much for walking us through it all.
My pleasure. It's fascinating stuff.
And for you, our listener, think about this. With all these diverse uses and ongoing progress, what could be next? Where might future breakthroughs in harnessing pressure and oxygen take us for healing and well-being? Maybe it's even more portable, accessible devices. Or perhaps digging deeper into exactly how it works physiologically inside those chambers will unlock totally new therapies we haven't even imagined yet. Something to ponder.